Yeah. Okay. All right. So, where was I? I was at aortic regurgitation. Just going to increase the size of this. Right. Yeah. Now let's go into the pathophysiology of it. See, when you talk about aortic regurgitation, okay, it can either be acute or chronic. Now, when there's left ventricular dilatation and eccentric hypertrophy, okay, as a result of increased volume of blood within the left ventricle, this results in a very high systolic blood pressure because the eccentric hypertrophy can cause a very strong strong force onto the blood, and therefore the blood can get ejected very with a much higher rate and power. So this can mean high systolic blood pressure, and during the diastole, because the aortic valve cannot close completely, the blood will flow back into the left ventricle, and now the pressure in the aorta is low. So if you compare the systolic blood pressure, okay, versus the diastolic blood pressure, the systolic blood pressure is very high because of the adaptations of the ventricle, but the diastole is very low because of the backflow. This means that the normal blood pressure of 80 during diastole is much more low, and this can create a hyperdynamic circulation. So examples could be 220 by 20, 160 by 50, etc. So this is the situation. Now the complication of this is heart failure and lung edema. Again, the way you remember this is most cases you can just trace the pathophysiology using logic, and you can talk about lung edema and heart failure. Now, the diagnosis for aortic regurgitation is quite a lot. Um, Murmurs, heart failure, palpitations because of extreme blood pressure, okay, extreme force or contractility of the left ventricle. And then again, there's no more contractility when it's getting filled. That, and then you can also look into pulsating nail blood because of the high systolic pressure, and even in the uvula in the oral cavity you can see there's a rhythmic pulsation as a result of the increased systolic blood pressure. The same thing can be applied to carotids as well. So carotids, nail buds, uvula, and also the head bobbing, which is like the head is moving with every beat. uh, these are all caused by the high systolic blood pressure and the hyperdynamic circulation. Okay, so remember hyperdynamic circulation, then you remember these, and connect this to increased systolic blood pressure and very low diastolic blood pressure. And by that, you can connect it to aortic regurgitation based on the pathophysiological mechanism. Okay, now your diagnosis can continue into ECGs, chest X-rays, and echocardiography. Tricuspid stenosis. Now we are talking about the tricuspid valve, that is on the right side of the heart, most common in females. Uh, Rheumatic heart disease, one of the most common causes of tricuspid stenosis, but it can also be carcinoid syndrome. The pathophysiology of this is nothing but increased right atrial pressure, okay, because of this stenosis. Therefore, blood accumulates in the right atrium. There'll be right atrial hypertrophy as an adaptation. And because now the blood from the vena cava cannot enter into the right atrium, or rather it's difficult for it to enter, there'll be congestion of the blood in the venous system. This can cause the veins to get engorged with blood. They'll have this haphazard, shape, and this can cause hepatomegaly because there'll be increased pressure within the portal vein. It can cause ascites. It can cause generalized edema with pitting edema, especially at the legs, and of course prominent jugular veins because this increased pressure in the right atrium. Forgive me if I've said left atrium at any point of time here, but the right atrium uh, can propagate to the jugular veins, and over here there can be some sort of a distension as well. Complication over here would be right heart failure mainly. And the diagnosis is again ECG, echocardiography, chest X-ray, murmur, and any sort of other sounds. So that is tricuspid stenosis. Now, what about regurgitation? Now, regurgitation can be caused either by functional causes or organic causes. By organic, I mean by intrinsic damage, that is damage to the valve. This could be again inflammatory causes, carcinoid cause, and it can also be a malpositioning of the malpositioning of the valve. Okay, it's a congenital defect. And the functional cause could be, for example, due to right ventricular dilatation, okay, which could be as a result of pulmonary hypertension, which again could be caused maybe due to mitral valve stenosis, for example. Okay. Um, and of course, cor pulmonale. Now, the pathophysiology of this is that there'll be a volume overload, okay, because when there's tricuspid regurgitation, then the blood flows. Uh, it can there'll be a lot of blood that is getting accumulated within the ventricle. So there'll be ventricular hypertrophy and dilatation. Now the complication is right heart failure. The diagnosis, sorry, is all the signs of right heart failure, okay, of cor pulmonale, pansystolic murmur, and pulsatile hepatomegaly. That is, the liver pulsates with every systole because of congestion. Now, the treatment for an organic type would be typically a valve replacement, and for a functional type, it would be to just treat the underlying cause. Now, pulmonary stenosis. So this is present between the right ventricle and the pulmonary artery. Okay. Now, the causes of this could again be inflammatory. It could be congenital, and when I talk about congenital, just talk about tetralogy of Fallot, carcinoid as usual, and rubella. Apparently, rubella causes pulmonary stenosis as well. Um, Now, pathophysiology of this is that due to pressure overload because of the stenosis, uh, pressure overload within the right ventricle will cause it to become hypertrophied, and again, it will lead to right-sided heart failure. Now, diagnosis, all the signs of right-sided heart failure, mid-systolic murmur, chest X-rays, you can see a prominent pulmonary artery and is supposed to be bulging a bit, I guess, due to dilatation. ECG, echocardiography, that's the standard answer for all of them. Treatment, again, for this could also be a valve replacement. So for stenosis, pulmonary stenosis, valve replacement. For tricuspid regurgitation, valve replacement. And I think even for tricuspid stenosis, I think you're quite sure that we can do valve replacement for this as well. Anyways, so we come to the last one finally, which would be pulmonary regurgitation. So the causes of this could be cor pulmonale, okay, pulmonary hypertension, infective endocarditis, again, damage to the pulmonary valve. It could also be, those are the cases. Now, one interesting fact is that a lot of the IV drug abusers can get pulmonary regurgitation or pulmonary insufficiency. It's quite common because they are basically injecting the drug into their veins, and through this, there can also be transmission of microorganisms, which can cause endocarditis. And if you imagine the flow of blood from the veins, it's going to go into the right side of the heart and into the pulmonary vessel, right, pulmonary artery, and can cause infective endocarditis. Now, just remember IV drug abusers for pulmonary regurgitation. Now, the pathophysiology. So what's going to happen here is, because blood will flow back into the right ventricle, there'll be hypertrophy and eventually there'll be dilatation. And this can result in volume overload. I mean, this can be due to volume overload, and this can lead to right heart failure. Now, let's go for the diagnosis. All signs of right-sided heart failure, early diastolic murmur, um, and treatment is valve replacement. So for pulmonary regurgitation and stenosis, you can do valve replacements. Same thing applies for tricuspid regurgitation, and I'm quite sure even for stenosis. But you might want to cross-check that. All right, now finally we come to the last part of the entire question, which is rheumatic heart disease. So before we start this, just to conclude, to help you understand what exactly you need to answer, because it's a very huge answer, right? For sure, in the exam, you won't have this much time to answer. So what's most likely going to happen is this. The professor might allow you to answer for about 2-3 minutes, and then he or she might start asking questions in between, right? And they can pick specific points and facts, and they can ask you questions based on that. So what you would want to do is you would always want to start off with the most basics, okay, with the most basic facts, which is what is a valvular defect, why does it occur, and the different causes of it, okay? And then which where you can just mention the ones highlighted in red or highlight it or put in bold, you know. And even if you don't have time to learn this entire answer, just look at the red highlighted words, and I'm sure that will help you figure your way out through this answer pretty quick. But I have to say it's a very big topic to explain and to understand. So once you just talk about the basics, the etiology, and you can talk about what is the principle of stenosis and insufficiency and how are they caused. You can just throw this point that mitral valve is the most common target. Okay, that entire thing should take you about 2-3 minutes, and he or she might interrupt you and ask you more specific questions with regards to the valvular defects. He or she might ask you about um, so what exactly is happening in mitral stenosis? What are the causes of mitral stenosis? So you can just be specific to what they ask. And if they don't, you can just continue and you can mention just 2 or 3 points for causes, for pathophysiology, and for diagnosis, and you can go to to the next question. So you don't have to explain as much as I have done. I have done this only to help you understand and to help you go through the notes that are provided to you much more quick instead of having to spend hours together trying to understand what's happening. But in essence, just try to name a couple of things here and there, the top 2-3 points, and just move on to the next stenosis or insufficiency. Okay. Yeah, and same thing goes for diagnosis as well. Don't spend, I would suggest you not to spend too much time explaining about murmurs and heart sounds because that's a quite a detailed topic and you might not have time to explain the whole thing, nor would you possibly be in the position to explain in detail accurately what the professor wants with regards to heart sounds and murmurs. So better not to talk about that too much in detail. Mention ECG, just mention heart sounds, murmurs, just in general, you know. Right. So I hope that explains these points. And of course, feel free to ask us regarding any doubts that you might have. So now let's go for rheumatic heart disease. So rheumatic heart disease. I'll explain to you what's happening. So we have got a person, okay? He's infected with Streptococcus pyogenes or some sort of a group A beta hemolytic streptococci, right? First thing that's going to happen is pharyngitis, okay? Pharyngitis appears. That's a typical group A streptococcal sign, okay? Pharyngitis is going to happen. Then they might get rid of the pharyngitis. 2 to 3 weeks pass by, and then starts the manifestation of rheumatic heart disease. So what's happening? Essentially, the immune system of our body, okay, is has already detected streptococcal pyogenes or a group A beta hemolytic streptococci. So they produce antibodies. These antibodies can actually attack our own heart valves instead of attacking the bacteria after a certain point of time. And this is technically an autoimmune response, if you would call it. So, or rather, it's an immune response against self, okay? And what's going to happen is, as a result of this, there's going to be damage to the valve, right? The most commonly affected valve is the mitral valve. So more specifically, there is a hypersensitivity reaction. Okay, our immune system is going to create this hypersensitivity reaction to this uh, valve, okay, to our heart valves. And these antibodies that are created are actually directed against the M proteins of the streptococcal pyogenes, okay, or pyogenes, I think it is. Um, So the heart is the only organ that is affected chronically during rheumatic fever. Okay. And typically, rheumatic fever is a multi-system inflammatory disease that involves many organs. And within these organs, heart is one of the main ones to get affected. And that's what we're going to focus on more. Now, epidemiology, when you look at rheumatic fever, is affecting many children between the age of 5 and 15. Before the age of 5, it's quite rare. After the age of 15, it's can also be rare. Um, what can happen is the antibodies will act against these cardiac valves. They'll activate complement and T helper cells, and these will naturally elicit a cytokine mediated inflammatory response. And then this entire um, situation will basically cause non-suppurative inflammation. Okay, because it's technically the hypersensitivity reaction. It's not exactly a bacterial infection that's occurring on the valve. And obviously, these antibodies are going to act against the joints, the skin, the CNS as well, along with the heart. And this creates something known as a Jones criteria, which I'll come to in a moment. Now, it's important to note that, uh, yeah, if you look at the Jones criteria over here, so you have something called as a major criteria and minor criteria. So for major, just remember Jones. For minor, remember cafe, as in cafe, coffee, cafe, and PAL, PAL. Okay, these are some additional ones. If you want to diagnose them, you either take a throat culture growing, or if you look, you can look at anti-streptolysin or titers within the blood, or and you can also look at two major criteria of these Jones. Okay, you can do that, or you can take the same thing, okay, look at elevated anti-streptolysin or titers and throat cultures, and combine it with one major criterion and two minor criteria. So look for these. So either in either pathway, if you can, if there's a positive result, it can mean that there could be a rheumatic fever. Now, uh, over here, it mentions that, see, it's important to note that only a small minority of infected patients develop a rheumatic fever. And this is mainly explained by genetic susceptibility to the development of that cross-reactive immune response. So not all people develop that immune hypersensitivity reaction. Okay, it's more of a genetic situation. So J stands for joint involvement. It causes migratory polyarthritis, typically swelling and pain in large joints. Resolves within days and migrates to involve other joints. It can be healed without complications. Then comes O. O looks like a heart. I don't know how, but well, O looks like a heart. Think of pancreatitis first. Okay, essentially it means all layers of the heart can get affected. Endocarditis, myocardium, and even pericardium can get affected. So endocarditis is more commonly involved. The mitral valve is more commonly involved compared to aortic valve. Okay, and in endocarditis, here you have small vegetations along the lines of closure. Okay, I think I have a picture for that. So you can look at this. You can see that there are these small bumps, right? So these are the rheumatic vegetations on the mitral valve. Oh, sorry. Okay. Now, so these are small vegetations along the lines of the closure, and they can lead to regurgitation. Remember, in regurgitation, I mentioned three main reasons. Number one, something is preventing it from closing properly, for example, cardiac tumors. Another example is these vegetations are these vegetations which can like prevent the complete closure, so there can be spaces within the space in between the valve leaflets and cause backflow. Myocarditis. So myocarditis can also occur, but just know that in the case of acute phase of rheumatic heart fever, myocarditis is the most common cause. Then pericarditis. So when there's inflammation of the pericardium, what can happen is there can be frictional rub against surrounding tissues, and can also cause chest pain because of irritation of the nerve endings. So J O is done. And now N stands for nodules, so subcutaneous nodules. E stands for erythema marginatum. So these two are related to skin. S stands for Sydenham chorea, related to CNS. Okay, so here there's just rapid purposeless movement. So without having a clear purpose of, let's say, grabbing a coffee or a mug, they just have rapid involuntary movements. And this is due to an attack of basal ganglia, which basically controls has got an inhibitory and excitatory effect on the motor neurons, to put it in a more simple format. Now, the minor symptoms, minor criteria is increased CRP, arthralgia, fever, and elevated ESR, and can also include other elevated acute phase reactants. Now, diagnosis, what I mentioned, either you take two major uh, or one major and two minor features. And then you also do it based on serological testing of DNAs and streptococcal antigen streptolysin O. All right. Now, coming more into rheumatic heart diseases, okay, remember I told you there will be pancreatitis. So you talk about endocarditis, myocarditis, and pericarditis. Okay. So pericarditis, again, fibrinous X-rate causes irregularity on the surface of the pericardium, can cause frictional rub, can cause chest pain, can resolve without complications. Sharp and well localized. This is in comparison to the more dull and ischemic pain that can surround and can propagate to the arm and to the back. In the case of ischemic heart diseases like cardiac arrest and heart attacks, and also when you do auscultation, that rub can cause this scratchy sound to be produced. It's more of a, I don't know if you can hear this to the speaker, but like if you just, you know, rub your hands like this, somewhat similar to that. And there's no long-term complications in this as well. It can be, fibrin can be dissolved by a plasmin. That's why in case of myocarditis, interesting fact, um, this is a pretty serious situation, can cause death in acute rheumatic heart fever. Here, if you look at the myocardium, okay, what's going to happen is you're going to have this area over here, which is consisting of, it's mentioned over here, 1 second. Where did it go? Anyways, you're going to have lymphocytic cells, you're going to have macrophages, oh, it's right here, plasma cells, T lymphocytes, and by giant cells, I mean giant macrophagic cells over here, okay, and surrounding this, okay, you're going to have damaged myocardium, and this entire uh, complex, okay, is technically a granuloma, and this entire complex, there are multiple complexes like these that surround a vessel, okay, so they're present in the perivascular connective tissue. Now, we also have some fibrinal necrosis around, because you're talking about the vessels, and necrosis of the vessels is typically fibrinal necrosis. You can also have, and it's, I don't know how to pronounce this, but anetskosis. And again, these are macrophages, and they have rod-like nucleus. Well, I'm not sure if you can see it clearly over here, but some of these have, I think this one is a good idea. They can have some rod-like nuclei. It's actually the chromatin that is arranged in a rod-like format, whereas most of the other cells can have a more rounded nucleus. Um, so that's Ashworth bodies. Then you have endocarditis. In endocarditis, typically the valve gets affected. You'll have fibrinoid necrosis. You can also have verrucae bodies. Verrucae, these are small vegetations along the line of closure of the valve consisting of fibrin and platelets. And these are fixed, so they don't break away and embolize. Early complication is actually the mitral valve regurgitation, whereas a long-term complication is a stenosis. And this is mainly because first, when these vegetations are formed, they're going to prevent the proper closure. However, in long term, they can cause fibrosis and calcification. And this can cause adhesion of the valvular cusps and can cause stenosis. Okay, so first you have regurgitation, then you have stenosis. Just if you want to differentiate between which comes first, understand the pathophysiology. Vegetations are formed, then they get fibrosed and calcified. They can also affect the aortic valve actually, and they can produce a fish mouth-like appearance of the valve. Um, Again, you can just remember this point as an extra. And all of these are predominantly in cases of acute rheumatic heart disease. I'll just highlight this. In the case of chronic rheumatic heart disease, okay, what's going to happen is whatever happens in acute inflammation happens, and then there'll be scarring of those. So the Ashworth bodies that we found in acute will get replaced by fibrous scars. And even these vegetations can get replaced by fibrous scarring. Okay. And over here, remember I told you that the valvular stenosis is a long-term complication. By long-term, I mean chronic. So we mostly or mainly find valvular stenosis rather than regurgitation, which was early complication. Mitral valve is the most common one to be involved. Uh, And obviously, with mitral stenosis, you can mention about atrial fibrillation happening and all the other pathophysiological mechanisms that we had mentioned earlier, thrombosis, uh, the pressure can get transmitted through the pulmonary veins and into the lungs, and then from the lungs, it can get into the right side of the heart. That can cause right ventricular hypertrophy and failure. That's it. So, what do you find in the chronic? You'll find fibrosis, right? So, thickening. Then fibrosis goes to calcification. There'll obviously be fusion because we're talking about stenosis. Choroid tendineae are also damaged, so they're shortened, thickened, and fused. You can see over here. So, let's look at this. Look at the black arrow. This is a fibrous thickening of the valve. Clearly, you can see that the valve is thickened, right? This is the anterior part and this is the posterior part. So it's thickened. Then you can see that over here, they are fused, right? So this is fusion of these valves. So that's what happens. And complications for chronic rheumatic heart disease, mention whatever is in mitral stenosis. And also you can mention infective endocarditis because when there's a predisposition, or not predisposition, but when there is a predisposing factor for the loss of integrity of the valve will not be very resistant to further complications, and one of that is infectious endocarditis. Now, diagnosis is 2 to 3 weeks after pharyngitis, you can look at the symptom. Labs, ASO and anti-DNS B titer, then look at the Jones criteria. The diagnosis and treatment is crucial because here's the thing. So we know the age group is between 5 and 15, right? Now, let's say there is a child that arrives with swollen, painful joints, which is part of the J of the Jones criteria, okay? Now, if you don't suspect rheumatic heart fever, then you want to treat it. And if you don't treat it, then then the complications would be more severe. There could be myocarditis and it can result in death. Okay. Now, if it is RF, okay, if it is RF, this happens. If it is not RF, okay, and if you just give treatment for rheumatic fever, then you'll be giving useless treatment for rheumatic fever, right? And another thing is this. Uh, you could have migratory polyarthritis, which is the main manifestation of the J part of Jones, right? So you shouldn't give aspirin until you recognize the migratory nature, okay? And then you recognize for sure it's a rheumatic fever. And because you must also know that it's quite dangerous to give aspirin when there is fever in children and in smaller in younger age groups, um, because it can cause encephalitis, hepatitis, and I think it's called a specific name. I forgot about that. But yeah, now patients with previous RF should receive prophylactic antibiotics for a long time in order to get rid of all the possible complications and remission, not remission, sorry, of the disease occurring again. So to conclude, um, how would you answer this question? Mention what rheumatic heart disease is. It's a inflammatory hypersensitive reaction, okay, caused by the body, and the antibodies are aimed against the M proteins of Streptococcus pyogenes and other gram and group A beta hemolytic streptococci. Mention that first pharyngitis appears, then 2 to 3 weeks later rheumatic heart disease appears. Mention about epidemiology. Mention the Jones criteria is quite important. Briefly mention about J, S, the CNS, and the minor. Don't mention too much into detail. Only if they ask, you can go more into detail. So that is Jones. Then come to the O part, that is the heart over here. And here you mention more into depth. You can start off with this, okay? You can start off with just this much. Don't explain anything further. If you think that you have to explain more, maybe because you haven't explained other parts properly, or maybe because the professor asks, or maybe you just think you know it well, then go for the acute rheumatic heart disease and chronic rheumatic heart disease. In acute rheumatic heart disease, just mention, remember pancreatitis for acute rheumatic heart disease, and mention about endocardium, myocardium, and pericardium damage. Then go to chronic, mention the same thing what you mentioned in the acute inflammation part, and then just mention that they'll undergo scarring. The most important thing for chronic rheumatic heart disease that you have to mention is that valvular stenosis predominates regurgitation, and you have to mention why. Okay. For complications for all of these things, just talk about mitral stenosis. It's the best. Subsequently, you can also talk about the aortic stenosis, aorta, and then you can talk more about the tricuspid valve and the pulmonary valves, because if you remember the very first part of this entire video, I spoke about the decreasing order of um, susceptibility. Yeah, and that's pretty much it. Then just talk about diagnosis. Again, mention whatever I mentioned in the picture for Jones criteria over here. Where does it go? Yeah, this diagnosis part, okay? And just remember this is kind of important. And I think that should be it. I think this is more than enough. Again, if you want to talk about the macroscopic pathology of the valvular defects, you can do so. You can just typically mention about the vegetations. Okay, and I think I have a PPT for that, or a picture for that. I'm not sure. Just a second. Um, all right, not here. So it has to be. Oh, it's right here. My bad. Okay, so you can look into this as well. Uh, Let me just put this picture here. So over here, you can clearly see that for rheumatic heart disease, these are small vegetations. Whereas if you're looking at infective endocarditis, they are like large vegetations that can even destroy the chorda tendineae and the papillary muscles. For non-bacterial thrombotic endocarditis, which is basically part of non-inflammatory, non-infectious endocarditis, these are larger. And for the case of Leibniz-Sachs endocarditis, which is caused by, I think, lupus, uh, you can look at the fact that these are large and you can also have it on both sides of the leaflet, whereas this is typically at the edge of the leaflet. Okay, so you can talk about that. When it comes to macroscopy, you can talk about what I mentioned over here for macroscopic pathology. You can mention, you don't have to mention too much in depth, just mention that there'll be inflammatory signs, so there'll be redness, there'll be fibrin exudate, because these vegetations contain fibrin, they contain inflammatory cells, macrophages, they contain possibly bacteria as well in case there's infective endocarditis causing these valvular defects. And you can mention that there can be a rupture, there can be fragmentation of the valve, there can be rupture of the chorda tendineae. You can mention the dilatation of the left ventricle, right ventricle, left atrium, hypertrophy. So these are all the macroscopic pathologies that you mainly have to mention. So it's not it's more of logic based when it comes to macroscopic pathology in this situation. But if you want to know more about it, you can definitely look it up on pathologyoutlines.com and other places. But I think this is more than enough for the exam. And what's up? Yeah, so that's pretty much it, I believe. This is again another picture of the vegetations, small vegetations on the rheumatic heart disease. You can see how it's bulgy in nature, they're small, rounded. So these are the kind of words that you need to use for explaining. And yeah, that's pretty much it. All right, so thank you. I'm really sorry that it's a very long video. There's a lot to explain, and I'm sure when you go through it yourself, you're going to realize how big it is. Hopefully, you can shorten it. Um, my presentation here was to mainly help you understand, rather than to give you a proper word-to-word script of what to answer in the exam, because understanding is very important in this huge question. And I'm sure you can come up with a much shorter version of whatever I've mentioned for your final examination. So all the best, and thank you. Right.